Ladies and gentlemen, thank you very much. This is our Health and Hospital Committee for the County of Santa Clara. The hour of 3 o'clock has arrived, and we are scheduled to have a somewhat shorter meeting than typical today, 3 to 4:30. So I just give everybody warning, and that means we may have to put some items on consent and/or continue some items and/or forego our own questions. So I will move right ahead and say the first item of business is to call the roll and establish the presence of the quorum. Madam Clerk.
All right. Vice Chairperson Lee.
Aye.
And Chairperson Simitian.
Here.
Thank
All
you.
right.
You have a quorum.
Both members present accounted for. That takes us to public comment. Public comment is that portion of our agenda which is set aside for comment by any member of the public on a non-agendized item, something that is not on our agenda today, but that is properly within the jurisdiction of this committee. So if you would like to comment under public comment, this is the time. Do we have any cards, Madam Clerk, from folks here in the chambers? Let's start there.
Okay. So we don't currently have any in the chambers, but we do have 2 hands raised virtually.
All right, let's take those 2 virtual hands and say we're going to cut off the hand raising after we get through that first speaker. So let's welcome our first speaker, and he or she may have up to 3 minutes under the rules of the board.
Under 3 minutes, no problem. All right, so our first speaker is Ken Horowitz. Ken, we are currently unmuting you. You have 3 minutes to speak. The timer will begin when you begin speaking.
Good afternoon. This is Dr. Ken Horowitz of the Your Health Advisory Commission. And I wanted to announce that this evening, right after your meeting, at 6:30 in room 157, our Health Advisory Commission is hosting a number of speakers regarding telehealth. We are going to have Dr. Michael Waugh, who's Chief Medical Officer of Santa Clara Valley Healthcare. He's going to be talking about acute telehealth services offered by Santa Clara Valley Healthcare. We'll then be followed by Leah Rosengaus. She's Director of Digital Health for Stanford Healthcare. And finally, we're going to have a speaker from Stanford Healthcare Telestroke Program. And all of these 3 speakers are going to share with the commission what's currently going on with digital or telehealth. And then, of course, follow up with a report to you, the Health and Hospital Committee, regarding our particular findings. Our program is being run by Dr. Sri Krishnan and Mike Rogers, who are the individuals in charge of our ad hoc program on telehealth. So we'd like to invite anyone who's interested in telehealth and what's going on in the county to attend tonight, starting 6:30, room 157. And if we, the commissioners, will be in person, but should you wish to participate virtually, you can go on to the website, sccgov.org, and find the Zoom link, and you can participate in the meeting as well. So thank you for your time, and I hope you have a good meeting today. Thank you.
Thank you very much. Let me just confirm with the clerk, still 1 person in the queue?
That is correct.
All right, let's hear from that 1 more person, and then we will move on to the consent calendar.
All right. Our next speaker is Michael Rogers. Michael Rogers, you're unmuting you. You'll have 3 minutes to speak. Please go ahead.
Hi, I'm Mike Rogers, the Vice Chair of the Health Advisory Commission, along with Ken Horowitz. I'll try and be brief here, given your shorter schedule today. A little over a year ago, we presented to you on chronic illness and proposal for a discovery process towards an integrated and functional medicine pilot within the county health system, since it is devoid of such services currently, but it is available in other services in the Bay Area and in the South, in Santa Clara County. Pleased to give you an update on that through Dr. Huino and Michelle David-Kaya from the County Health System have reported to us that they have had a task force that's been meeting monthly for several months now with a variety of clinicians in different disciplines and are making progress towards defining a pilot. So at some point in the future, either they or we will come back with a little more detail on that one, but that's an update on something you guys approved just a little over a year ago. Secondly, one of the things we are doing tonight is we work aggressively on our work plan, and we will be reviewing and looking at our work plan for 2023 and 2024. I'm not going to go through the details of that, but our preliminary discussions indicate we'll probably continue almost all the items which are still in orders, works in progress. But the thing I would ask is specifically of the supervisors and their staffs, if they have any inputs on things they would like us to be working on, please let us know, because we will be finalizing. We don't have to finalize it until May, but we will probably be finalized by March and have it reported in and submitted to the supervisors. Thank you for your time and attention. Appreciate all you do.
All right, thank you to our speakers. Let me just confirm with the clerk that that is all of the speakers we have under public comment.
That is correct. It concludes our speakers.
Thank you very much. That takes us to item number 3, which is to approve the consent calendar and any changes to the committee agenda. And Supervisor Lee, a little back and forth here if need be, but given the time constraints we're operating under today, I know we have already called out on the agenda a number of items for the consent calendar, and they, of course, are indicated in our published agenda as items 14 through 18. But I am thinking that a motion to include item number 6, needle exchange, item number 7, STIs, item number 9, the report regarding the 6-month update on AOT, since that's coming for a full update to the board later this year, and item number 12, regarding Medi-Cal eligibility redetermination and community outreach. All important topics, but I think they're relatively squared away. I would ask for a motion to approve the consent calendar as contained in our published agenda with those additional items, and holding item number 8, the Valley Healthcare report on CalAIM, to our March meeting.
So moved.
And
Oh, sorry.
if you're amenable, I'd like to rearrange the order for the remaining 5 items so that we take up, hang in here with me, everybody, item number 4, followed by item number 10, followed by item number 11, item number 5, and then item number 13 at the very end. So if the supervisor is agreeable, we would take up items 4, 10, 11, 5, and 13
Yes.
in that order.
That's fine with me.
And that is added to the motion. I will second it. And let's see if we have any speakers on the consent calendar and committee agenda.
Okay. And just to clarify, that means that we are moving items number 6, 9, and 12 to the consent calendar. We shall hold item 8 to the March meeting, and we are going to be, and the order of the items right now will be 4, 10, 11, 5, and then 13, correct?
Along with item 7 on the consent calendar, which
Number
I don't
7.
think you mentioned, Madam Clerk.
Okay, 6, 7, 9, and 12, correct?
6, 7, 9, and 12 on consent. Item 8 held, and then the reordering on the other items.
Okay, perfect, thank you. And we currently do not have any requests to speak.
Okay. Then we have a motion by Lee. I will formally second the motion and ask you to call the roll.
Vice Chairperson Lee?
Aye.
And Chairperson Simitian?
Aye.
Thank you, motion passes.
Thank you very much. Then that takes us to the first item still on our regular agenda, which is item number 4, to approve inpatient and outpatient privileges for physicians at Valley Medical Center. Do we have someone here? Mr. Lorenz, you're
thank you,
not
Chair.
my usual suspect.
Yes,
Actually,
Doctor?
is it-
he is online.
Yes, I am online. Yeah, thank you, Mr. Lorenz. This is Harry Morrison. I'm the enterprise president of the medical staff. I'm here to present this privilege set and the Enterprise Medical Executive Committee report and answer any questions.
Thank you. And I have your disembodied, now I have you. It's Dr. Morrison, yes?
Correct.
Thank you, Dr. Morrison. We have a request, Supervisor Lee, for approval of privileges. Would you like to make a motion to do that?
So moved.
Motion by Lee, second by Simitian. Let's see if we have anybody who wants to speak to that item, Madam Clerk.
There are no requests to speak.
Okay. Dr. Morrison, I think you're about to get yes for an answer. You good to go?
I am. Thank you.
All right,
Thank
let's
you,
call the roll
Supervisor.
then.
All right. Vice Chairperson Lee?
Aye.
And Chairperson Simidian?
Aye. Motion carries unanimously. Thank you very much. That takes care of privileges. All right, that takes us to item number 10, and a report from Valley Healthcare and FAF relating to efforts to establish the North County Clinic. And who's going to present on this item?
I'm Supervisor Committee Jeff Draper from Facilities and Fleet. I'm not there today, I'm sorry, but I'm here. So I'm happy to report that the progress on the project continues and that we have had a bump in the schedule this month, but we had enough slack in the schedule that we think will still pretty much open as originally advertised. With that, I'll stop and let you ask questions.
Thank you. I do have a quick question, and I may look to the county executive to help out here as well. The information on the slippage in timeline, which looks to be about a month, as I understand it, and please correct me if I'm misinformed, there was a certain lack of coordination around construction documents. And I'm trying to figure out where that problem came from, because, as I say, it's costing us time. And it's not that I want to chastise anybody, it's that I want to make sure we don't have a repeat. So is it the property owner? Is it the contractor? Is it our own planning department? Is it Facilities and Fleet? Where did this, we're working with our own planning department, who presumably understands the priority that's being placed on the project. So my question is, where's the problem, and how can we make sure we don't have a second or a third occasion?
Of course. If I could take the first stab, Supervisor.
Please.
Normally, and as you can understand, there's various disciplines like the architect, the mechanical engineer, the electrical engineer, and so forth and so on in a project. And everyone has to get their drawings coordinated with each other to make sure they all fit into the spaces and so forth and so on. The primary responsibility belongs to the design professional. That's where it belongs the most. And then we move on to, it's not the construction contractor, it's not the landlord, although they own the architect, so to speak, in this particular project, because this is a lease tenant improvement, meaning that the landlord runs the improvements. I think that Facilities and Fleet owns some of it as well at times, because we have to oversee the whole project. And so in this case, I put most of the requirement at the architect's feet, but that doesn't mean that the rest of us don't share. And I will leave it at that.
Well, maybe you could tickle the architect's feet.
How could we improve? How can we improve? So, again, I believe the landlord's project delivery team owns the project. Our job is to give them the program to build to, for the most part. And as long as we stick with the program to build to, then the rest is on that project delivery team.
All right. Well, what I'm trying to avoid is having different folks pointing the finger of blame or responsibility at other folks. And, that's when a team works together, that's always going to be a bit of a challenge. But anything we can do to improve the communication, because, there are clearly delays that are unavoidable. I was not convinced that this was one of them. It seemed to me that this was one where if everybody had been working hand in glove the way we hope, that this is time we might not have lost. So I do have, I want to pivot slightly, but I want to look to our county executive, see if he has any comments he wants to make. And if not. But Mr. Draper, it was a long time ago that Mr. Lorenz and I stood outside that building and said, we're good to go. We took a long time to plan. And the theory is sometimes you have to go slow to go fast. But I feel like we went slow and are still not going fast. Let me put it that way. Mr. Williams.
Yeah, I don't have a lot to add on this particular project. I think this is a real issue. It's a real challenge, especially when we have a lot of different entities involved. I know we've had challenges in the past with projects where we've been dependent on landlords to move on their contractors too, and had to work through that chain. And so, it's definitely an item that is a continued work in progress to make sure that we keep things on track.
All right. I'm going to be a little careful looking to county council here because we don't have the De Anza Clinic agendized, but I can't help but ask some questions about the De Anza Clinic feasibility study based on this report. And I guess, Mr. Draper, you still with us?
I am.
Thanks. I want to look to you and to the county executive. My recollection is that we're going to get sort of an oral report at the February 14th HHC meeting, and then a written report to the board at its February 27th meeting. And I just want to make sure that whatever funds are needed to complete the feasibility study are in fact allocated, approved, that so that we're going to get a real feasibility report at the meeting on the 27th. Is that all in place?
My answer is yes.
And then where does that leave us with that project in the queue, so to speak? It's a capital project. So what's the status there? So let's based on what we've heard to date, which has been encouraging, I'm hoping you're going to come on the 27th and say we can go. And if the board says it shall be done, it shall be done. And what are the financial implications of that? Because I don't want to have a surprise there.
Before we get into the financial applications, Supervisor, I know I'd like to answer your question straightly, and that is, we still have some reliance on some of the process at the De Anza campus to get through their process, so to speak, with their stakeholders. Our job is to bring back some blocking diagrams, as they call them, massing diagrams for the site. They've asked for those to facilitate their meetings. I'm not exactly 100% sure as I sit here and talk to you right now what their schedule is. And I can tell you our blocking, our massing diagrams are eminently due to them. So I'll stop there. But in terms of feasibility study, your feasibility study will be done in February, and we should be able to report that at the end of the month. All that we were lacking were some geotechnical issues. We've resolved those, and the report is due to us on February 9th. We expect the feasibility study to be cleaned up and issued to you, so you know what the budget for the project might be. And then the next step is obviously how do you fill in the budget? And I'll leave that to the county executive.
I will just offer this one last observation because, again, it's not an agendized item, and I want to respect that and not try to provide too much direction on it. But part of the reason I asked the question earlier about the North County site is I want to make sure we don't have a situation here where you're saying, well, we have to get some stuff to Foothill De Anza, and then you tell us, well, we got the stuff to Foothill De Anza, and then the folks at Foothill De Anza come to us and say, we don't have the stuff we need to make a decision. So, I just want to exhort all parties to be very clear with one another about the fit between what was expected and what was delivered, so we don't lose a month just because somebody said, oh, it came in the wrong color paper or whatever the problem was. Mr.
If
Williams,
I could also offer,
yes,
before James might answer, the CEO might answer, that is, we're at a place in our budgeting process that obviously I know the county executive is working hard with us and others to prioritize the budgets looking toward fiscal year 2025. And I'll leave it up to him to answer that, so to speak, after this.
thank you.
So once we receive the feasibility analysis, I think we'll have a sense of costs. This is not a currently funded capital project, as you know. We don't know what bandwidth there will be in the upcoming budget for proposals for new capital projects, and we'll be seeking direction from the board in the context of the overall budget. So don't have an answer right now, but I can share with you what I told FGOC this morning at a public meeting, which is administration's priority is to try to identify funding for the completion of those projects that are currently underway as the top priority, and then seeing what additional funding is available thereafter.
And not to be a semanticist, but what's the definition of underway?
Underway is typically where the capital project has been funded such that there was design work. I mean, the most underway is under construction, like the behavioral health facility at the VMC campus where there is a funding gap. That project is under construction, so our top priority will be to identify the remaining funds necessary to complete the project that's obviously half built, literally. But underway also includes projects where we have expended funds on the actual design work and begun the public works kind of contracting process, which is a costly and laborious process, as you well know.
So to circle back to the item that's actually on the agenda, the North County item, that would be underway by definition.
Yes.
Thank you. Supervisor Lee, I'm going to turn to the clerk and see if there are any speakers on this, but otherwise I want to turn to you and ask if you have comments or questions.
No further questions. Ready to make a motion to receive the report.
All right. Motion is to receive the report. I will second. Thank you all. And Madam Clerk, there are no speakers, just for the record.
That is correct. There are no speakers.
Please call the roll.
Okay. Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Thank you.
Motion
Motion
carries
passes.
unanimously. Thank you very much. That takes us to the next item, which is item number 11 in our restructured agenda. And who's going to present on this item?
Good afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell, Director with our Behavioral Health Services Department. And we have Bruce Copley and Mago Lien here from the department who will provide some information on this report.
Welcome all, and if you would master the mystery that is those microphones, that would be a good start. And if you would lean in and loudly and clearly tell us your name and your job title so we know who's sharing what with us.
Hi, Bruce Copley, Director, Access Unplanned Services, and I'm here with Mago, who provides the suicide and prevention services for the department.
I'm Mago Lien, Prevention Services Division Manager with Behavioral Health. Go ahead.
Mark Rodriguez with Senior Management Analyst.
Last name again, sir?
Mark Rodriguez.
Mr. Rodriguez, thanks so much. All right, please begin.
Okay, so this is the fiscal year 23 Suicide Prevention Annual Report. Go to the next slide. So in the last year plus, we've done some work to really understand this trend in the data that you're seeing here on this slide over the past 5 years. This trend is actually mirrored at the national level as well, where we saw a slight decrease in the suicide count and the rate during the initial years of the COVID pandemic, followed by an increase in 2022. And there's a lot of different factors that influence suicide trends, but there are some studies pointing to certain factors that may have been protective against suicide during the pandemic. Things like governmental financial supports that were offered and more contact with family and loved ones due to social distancing measures. There were also documented increases in depression, anxiety, and substance use during the pandemic. And so with our stakeholders, we've been discussing that the increase you see in 2022 could be a delayed effect of those increases in mental health concerns. We also noted that there was a larger number of suicides in 2022 that were by non-residents of the county. We took a look at those 21 suicides and didn't see any standout differences in the demographic trends among those individuals, but it is worth noting that those individuals were not exposed to the suicide prevention programming from the county. On this next slide, another trend that we're focused on is a few years of increases in suicides among the Latinx and the Asian communities in the county. And these have been happening at the same time as decreases in suicides among the white Caucasian population you see on the right-hand side of the slide. And this population has always accounted for the largest number of suicides in the county. This disparity that we're seeing could be in part due to the disproportionate impact of the COVID-19 pandemic and effects on communities of color. At the program, we're currently increasing outreach and gathering research on mental health and suicide for these communities. And we have an update on this coming back to the board at a later report. Finally, one more trend we're looking at and focused on is the rise of suicides by hanging relative to suicides by firearm in the county. So 2022 was the 5th year in a row where hangings were the most common method And you see here the green chunk of the chart where it's nearing half of all suicides in the county that are by hanging, 43% in 2022. So while the decrease in firearm suicides could be attributed to firearm safety policies and activities, there's close to no evidence to really support effective hanging safety means measures outside of hospital or jail settings, so in community settings. So this is a real challenge. The stakeholders on the next slide have tried to start and address this. Thank you. To address hanging means safety in the past year. So they've reviewed the literature and decided to focus on education about this issue. In fiscal year 23, we developed educational materials about this issue. This is an example of the brochure developed for caregivers, including information on how to talk to a loved one about suicide and creating a safe home environment. We also developed a brochure for providers like school staff and clinicians, and a fact sheet for the 988 call staff. Next slide. So just some other highlights from the program's work in the last year. We developed campaigns to spread awareness about the new 988 service, which launched last year, and they received nearly 57,000 calls in FY23. School staff, through our partnerships from 20 school districts, receive support and trainings in suicide prevention and crisis response. And our partner, CCPA, supported ambulatory care, Momentum for Health, and Asian Americans for community involvement with system improvements to more effectively identify and support individuals who are struggling with suicide. And then one highlight from our more community level prevention, in the past year, we were able to really increase our investment in youth development activities that build protective factors against suicide, like leadership, purpose, sense of purpose, and connection to trusted adults. So as you can see here, the activities are really diverse. They range from technology and media to community service and culinary skills. And these are done in partnership with CBOs across the county. So in this fiscal year, we had 2,690 youth who participated in this programming, and we started piloting evaluations for the activity's impact. So that is our report, and I can take any questions.
Let me check first with the clerk to see if there are any speakers on this topic.
There are no requests to speak.
I think I heard there are not. Is that correct?
That is correct, there are not.
Thank you. Supervisor Lee?
Yes, thank you so much for the report. Very educational. I'm certainly very disheartened to see that our number has increased in 22 compared to the previous years. Certainly want to thank BHSD.
Excuse the interruption, Supervisor Lee. I think you may need to lean into that microphone a little bit more.
Okay, let me try to do this.
Thank you.
So I just want to thank the BHSD and the Prevention Services Division for the good work that has been done to improve these prevention services, raising the awareness, and working collaboratively with so many entities and stakeholders. The content reported in both the ledge file and the annual report are certainly excellent and show the strong commitment from the county to expand these suicide prevention efforts. In order to support the continued work of the Prevention Service Division and all the partners who contributed to the FY23 suicide prevention and annual report, I'd like to request that the administration also expand on the progress report for the 6 key objectives by, I guess, reporting back to us in April with some suggested next steps for each of these 6 objectives. Would that work?
Sure.
Yes, okay. And then separately, I do have a question regarding the follow-up, because as I learned in terms of the prevention work of suicides, a lot of times suicides are not successful in the first try. As a matter of fact, most of the times it actually fail unless you use a handgun, for example. So my question is, do we have any type of specific program that we track those who have attempted suicide, and what type of follow-up work we have in terms of the county services provided to those who have previously attempted suicide?
Yes, we have, through our interventions work group, tried to engage this group before. We developed some resources for people who have attempted suicide in the past. We did attempt to also put together support groups, but this was pretty difficult because there were kind of clinical challenges. And it was difficult to kind of recruit people to come help us develop this program. There weren't a lot of members who were willing to openly talk about their attempt experience, and that we're in a good place to be able to help with program development.
And is that program still ongoing, or has it stopped?
It hasn't been ongoing, no. But the resources are available. We ended up developing resources that we give out in the community.
But in terms of follow-up, that's what I'm worrying about is the resource there. So these individuals would have to seek resources themselves instead of us going out and offering it to them on an ongoing basis?
Yeah, so the resources are, we kind of collated what available at suicide attempt support groups are available in the community or virtually from the state, for example. And those are available that we can share with people who are looking for them.
Do we track folks who have attempt suicides, like check on them every month or a few weeks or periodically just to make sure, and then of course, if they do come back and actually succeed on suicide, is there a way we could track these data?
We receive data retrospectively from the state. They do provide data on who's attempted or who's been hospitalized because of either suicide attempts or ideation. But we're trying to get it as quickly as possible, this data, but right now it's a couple of years after the fact. But maybe at the hospital level, they would be tracking this, or at the clinic level on a more real-time basis.
Hospital. Hi, Paul. Now you know what this is coming. Just checking with you to see, is this something that the hospital tracks in terms of attempted versus attempted suicides of individuals that come to see your office? And
We do track some data, but what I'd like to do is get back to you on an off-agenda report in terms of what we do in fact track from a data perspective.
yeah, I think it's so important to not just say the resources available, but especially it's hard to identify who might be committing suicide, but if they have attempted ones, I think they would be the best candidate for us to help monitor and make sure that services are being made, pushed to them, being available, instead of asking them to come forward. So if you could come back on off-agenda report to see how we could improve on that area, I think that would be very helpful.
Understood. Be happy to do so.
All right, and that's my motion. Thank you.
Thank you. And let me just try to recall, we have coming back to, I think it's to the full board, the discussion about gaps in mental health services for older adults that we've been pursuing. Am I remembering that sequence correctly? Somebody help me?
Yes.
And could I just ask, if the maker is amenable, that we ask when that report comes back, that the issues that you began to probe in this report about suicide prevention among older adults sort of get some time and attention when that report comes back to us, please?
Yep.
Okay, thank you. Motion then by Lee, second by Simidian. No speakers on the item. Let's say thank you and call the roll.
All right. Vice Chairperson Lee?
Aye.
And Chairperson Simidian?
Aye.
Thank you.
Motion carries unanimously.
Thank you.
Thank you.
Thank you again. And I believe that now takes us to our final comprehensive item, number 13, yes?
5.
Forgive me, number 5. I did not mean to do that to you, Doctor. The Public Health Officer's report on COVID-19.
Thank you very much.
What should we
Mr.
know?
Chair. So Dr. Sarah Redmond, Deputy Health Officer for the Public Health Department, and just a few brief updates for you today as we enter the new year, another year with COVID with us. So just a couple things I wish to share today. First, I do want to highlight for folks that somewhat interestingly, right now, we are again in the midst of a large winter peak of COVID. And so what you see in front of you is indicating at the end of the screen on the bottom that really all of our sewer sheds across the county are in high levels. and frankly, at about the same level, in some cases slightly higher than we saw at this time last year, or at the peak of last winter's wastewater levels. So that means there is a lot of COVID out there right now. If you are in a restaurant, if you are in a crowd, it is very likely that one or more people in there with you have COVID or actively infectious. But what we are seeing that's different from last year is that our hospitalization rates are much lower. So this chart shows the orange and below it red peak in the middle, where our hospitals peaked in terms of COVID hospitalizations last year compared to where we are this year, when we may or may not yet have peaked, but we're at the highest point we've seen yet this winter. And it is a much later point than we peaked last winter. So this continues to be the trend where each winter, while we have roughly the same or even higher amounts of COVID out there, fewer people are getting seriously ill, fewer people are dying. And we think this is attributable to the very good levels of immunity we have out there from COVID right now. And similarly, our death data, while always delayed from when the actual peak of disease is happening, again shows a further and even more drastic improvement from prior winter surges, where ultimately fewer people are dying. And when we do see those tend to be among the vulnerable populations, such as the older adult, very young, or otherwise seriously ill population. So from there, I'll go to RSV and influenza, where you see somewhat similar pattern at the bottom. You see our RSV data is similarly high to what we had at our peak last year. But likewise, I'll say that our hospitals don't appear to be quite as inundated with RSV as they were last year at the peak of our winter illness. From flu, you'll see there that on this graph, the flu levels appear lower than this time last year. We have received an update from our partner, our academic partner who helps with our flu wastewater data, that they are recalibrating their flu assay. So they are looking to verify, are we really this much lower than last year, or is there anything we're missing? And as we get new information from them, we'll update this group and update our county website. For those who track our regular website updates with this information, you'll note that we've paused regular updates while we wait to learn more. And then my last piece of information to share with you all is where we are with respect to vaccination for this winter season. At this point, about 35% of residents have received their flu vaccination, and about 20% are up to date with the new COVID vaccination. And then, as we've talked about previously in this body, we have new tools to prevent severe disease from RSV this year, but we were stymied by this brand new tool being very slow to roll out and get to folks, especially the injection that was intended for vulnerable infants. But we just learned that in the last week or two, the CDC has assisted in releasing an additional 200,000 doses across the country of this injection for infants. And so they've recommended that previously, while they were saying save them for just the most vulnerable babies, we can now go back to attempting to vaccinate with this new protective shot all infants who qualify, who are described here below. And so we're working with all of the entities in the county who serve pediatric and newborn populations to help get that information out. Final slide is just showing that while our overall up-to-date proportion in the county in the COVID shot is 20%, we are seeing that we've approached 50% or so for the 65 and older population, which is exactly the group that's most vulnerable to severe COVID disease. And so while we still want to see overall improvement in getting up-to-date on COVID, and it is not too late to do so, given how much COVID is out there right now, we know many more people will get sick before the winter surge is over. And we would really like to see better equity in terms of access for especially Latino and African American community members. But we are pleased to see how many of our 65 and older community members are getting up to date. And I'll pause there or stop there for any questions.
Thank you very much. Let me check with the clerk, see if we have any speakers on this item, either here in chambers or online.
There are currently no requests to speak. No requests.
Thank you. Supervisor Lee, I see you have your papers and your questions ready to go, so go to it, sir.
Sure, thank you. Thank you so much for the report, and it's heartening, certainly, to see that the COVID number is so high. I guess what's the good news in all this is the fact that our hospitalization rate and our death rates is actually lowest year after year due to the vaccination, due to the antibodies that we have been able to get through vaccination or through getting infected previously and surviving from it. So I think that in a way is a good news. Just to share my winter break is dealing with both my parents who have not had COVID before. They all been vaccinated up to date. Both caught it. end of December, and when this all happened in Canada, surprisingly. And we were able to actually get Paxlovid, and thanks to the generosity of the Canadian government, we didn't even pay for the medication, 5 days dosage, and they were fine. So I think, and seeing the effectiveness and how easily these medications being dispensed with, I just want to say that that worked great, but I assume this is the same thing here, right here in South County, correct? Dr. Raymond?
Well, yes, with a major difference. So I would say there are still very ample supplies of Paxlovid as well as other treatments necessary. We have now seen the privatization of these medications, which means that folks with insurance will have their insurance billed ultimately for their treatment. That said, there are multiple programs that ensure that folks who don't have insurance or who have large copays, should they have insurance, still have access to free Paxlovid. And that will be completely free until all federal supply is exhausted. So here in the county, we have multiple systems set up to make sure that regardless of your insurance, regardless of your ability to pay any copays or full costs, we can make sure that you get Paxlovid and get it promptly. But it is going to differ where you go to get it and whether there are upfront costs that are reimbursed depending on insurance status. So this is something we're monitoring closely and making sure it doesn't have major impact in getting people treatment.
Great, thank you. And given so many individuals are suffering from, COVID and cold-like symptoms now, there's certainly more need for folks to just know whether they might actually have COVID. So the need for COVID tests is definitely very much important. Being in Canada, I learned that various drugstores actually were given these for free. And I don't mean one kit, they actually give out 5 kits per box, which I thought was very generous, but also very effective. And then we can all immediately test and figure out that, lo and behold, my mask wearing and being very vigilant actually worked. As much as I spent so many hours with my parents and my aunt and uncle, who also caught it too, I was able to be healthy enough to survive and drive them around like driving Miss Daisy. Anyways, that being said, in terms of the free test kits now, how are we able to get those to our residents? And if they need them, are they still free or they still have to purchase at the pharmacies?
So there are multiple avenues for county residents to access free COVID test kits, and actually the supply the county itself has is still quite ample. So in addition to many folks being able to bill their insurance and pick up tests for free, or pay for them and get reimbursed by their insurance, which will differ depending on people's insurance status, anyone can go to the county's Better Health Pharmacy, which will be able to distribute packages of COVID testing completely for free for anyone who needs them.
Okay, good. And we give out, what, 1 or 2 kits per person?
I believe it's 2 kits per person per household. So if however many people you live with, you can send 1 individual from your household to pick up that many kits for the entire household.
Okay, very good. All right, and that's all I have. Oh, one last thing, actually. RSV. On the chart here, everything seems fairly normal, other than Palo Alto. If you look at the green color, that one is shot way up for this month. Any reading why that's the case for Palo Alto specifically?
I think we don't know exactly, and as we've seen by monitoring the wastewater for COVID now for so many years, we know that even though our county tends to, in general, fluctuate together, there can be small differences. So we can see one area of the jurisdiction spike a week or a month before another. In fact, that's what we did see most recently with COVID. That same Palo Alto sewer shed that includes also areas outside the county, including East Palo Alto, went up first and then was followed by the entire rest of the county. So while we do right-size our wastewater calculations by several scientific methods that help us make sure it's accounting for not just too many people coming to visit or how much rain came in that area at a given time. We don't know beyond that exactly why Palo Alto first, but often we do see a week or so in advance in that northern part of the county before we see the rest of the county follow suit.
So this potentially is a bad news where this might be coming to the rest of the county soon for the RSV?
I certainly can't say that for sure, but I can say that it is it has been the case previously that we see the entire county move generally in concert within a week or 2 of each other. And so while I don't know certainly what will happen in the rest of the county with respect to RSV, I would say it is likewise with COVID and flu, not too late for folks to benefit from taking steps to protect themselves against serious RSV. And so that's especially important for older individuals who can now get vaccinated, and for pregnant parents who can get vaccinated, and parents of young infants who can go get that protective shot before this.
And the age group for RSV eligibility is?
For the infants, it's 8 months and younger. There are some exceptions where older children are eligible as well, and folks should talk to their pediatrician.
And the seniors?
And the seniors, it's for 60 and over.
60 and older.
That's correct.
Okay, so if you're 60 and older and you hear about this message, go get your RSV shot.
Absolutely. Thank you.
Okay, thank you. And that's all I have. Thank you.
Thank you. Let me check with the clerk. Do we have speakers on this item? I saw a couple of folks approach. I do have a question or two. Mine are relatively
So we
narrow.
currently do not have any requests to speak for this item.
Okay. Dr. Redmond, and if this goes to somebody else, I'm happy to hear it. A very sort of narrow question, but what do we make of the fact that we have COVID tests with expiration dates on them that have come and gone, and yet we're being asked to tell people not to worry, the test is still good? And are we ever going to get to the point where the expiration dates are actually an accurate reflection of the expiration date? So just, trying to help people keep themselves safe, and if they don't have confidence in the test, then that's a problem. So.
Sure. Well, I can offer my best expertise, but I think ultimately we do defer to the FDA and laboratory experts in this realm. So what I understand is a couple of things. One is the initial expiration date that gets printed on the box is how far did they prove that that test was going to work? So if I run a study and say, I know this test works now and 3 months from now and 6 months from now, but I haven't tested it yet a year from now, and I've still got to get those tests out to people, I'm going to go ahead and print on the box, I know this is good for 6 months. But then if I keep testing my own tests, if I keep evaluating them after I've distributed them and say, you know what, I'm running proper experiments to quality check them, and they're still good a year out, and they're still good a year and a half out, they will issue updates to the expiration. And for the most part, that's what's happened. That they've said, at the time we pushed them out to you, we could only prove they were good for this period, but now we know better, they're still good. And so when that's the case, the county's working to get those tests out to folks with stickers as best we can print them, saying the expiration date has been confirmed to be updated, we know this test is still good. There's a second set of circumstances on top of that where the manufacturer or the FDA has not issued an update saying, since I sent this out, I've proven it lasts longer than I told you it does. But the best we understand about how the tests work still tell us that if that control line, and for those of you who've done an at-home COVID test, 2 lines means you have COVID, 1 means you don't, but the test works. As long as you've got that control line that said the test worked, it is demonstrating that the basis of the test is still functioning. If you don't have that control line, whether it's new, old, expired or not, throw it out and try again. But if you've got that control line, you should be able to trust the results of the test. And finally, if it's showing up as positive, if you've got the positive line in addition to the control line, that's the real deal. I don't care how expired a test is. If you've got a positive line, you're testing positive for COVID. So because we want people to have the best information we can get them access to, when we've got those tests that the FDA has said, we didn't know they were good when we shipped them out, but now we know, we want to get those to people. And then in the circumstance where somebody says, either I've got nothing or I've got a really expired test, we'd still rather they run that really expired test because that is going to give them some information. And so we may still be helping to distribute those as well.
Thank you. Are we at the point where we're going to be receiving tests that have more accurate dates on them now?
I don't have an update on that yet. To the extent we get an update from the FDA or the manufacturer, we print our own updated labels to make it clear we know this one's good until this new date. If we don't have that information, we don't print it, but we offer the best information we do have as we're handing out the tests.
Thanks. So I'm going to go from the granular to the big picture here. Looking at the numbers on folks who have accessed the most recent vaccine, and it's in my subjective characterization, a relatively modest percentage. Any concern that we've just sort of taken our foot off the gas on COVID-19 because people were tired of it?
I think that's a very fair question. I think in the public health department, there are very few people who would feel like we've taken our foot off the gas. And I think what that looks like is a lot of work to message, especially with trusted partners who represent communities that we know have been hardest hit by COVID, continuing to work with them, make sure we're getting information in the language people speak in a way they'll understand about why we still feel vaccination is important. I think in terms of outside the public health department, whether that message is being received certainly does vary. To some extent, I have some sympathy for folks who have COVID fatigue, but I think to the extent that we can continue to work with our partners, ask them to keep their foot on the gas to get that information out, the better we're going to do, until hopefully we see a point where I can tell you no matter what that wastewater looks like, our hospitals are going to be fine, even our vulnerable community members are going to be just fine. But I think it is going to take higher up-to-date vaccination rates to really get us there.
We've had some discussion in this committee previously about whether or not the COVID vaccination is going to become, I'll call it an annual event, consistent with or similar to a flu vaccination. What's your take on that?
Mm-hmm. I think the latest information we have, both in terms of indications from CDC's vaccine committee and FDA, is that they are anticipating and they are setting up systems to allow that, where they update the COVID vaccine every year to make it available and in line with what COVID is out there right now that is most affecting people, spreading the most. Whether new changes could come along and throw that into disarray, I don't know. So COVID's certainly done that to us in the past and humbles us all in that way. But I think my best information right now is I would say people should start to think about COVID as just like you get your flu shot every year, getting your COVID shot every year.
Thank you. And last question for me, and then I want to check again on members of the public who might wish to weigh in on this subject. The role that Paxlovid is now playing, how would you describe that for us?
I think we continue to have growing evidence that not only is it a safe medication, but it is really effective at keeping people out of the hospital and avoiding serious complications. I think there's still an open question about whether it has successful impact in reducing long-term complications of COVID, and so that's something else we continue to watch. So I think it is, for the folks who are fortunately not sick enough to need to be in the hospital, the next best thing to keep them out of the hospital once somebody does get COVID. And fortunately, still right now, we have very widespread and affordable access to Paxlovid all over the county, but I think there's still more work and to be done by the public health department and our healthcare partners to make sure that folks figure out when they think they might just have a bad flu that it's actually COVID by going forward with that COVID testing and then reaching out to access Paxlovid as soon as they know they have COVID so that we can keep them out of the hospital.
So, of course, it being me, I have one more question after I said I was done with my questions, which is I remember sitting in these chambers in March of 2020 when we were confronting the fact that there just weren't tests available. And I expressed my concern then that you can't fight the virus if you can't see the virus, and you can't see the virus if you don't have tests. That's my layman's way of saying that. And do we feel like there are, to the earlier conversation that Supervisor Lee spoke, that there are enough home tests out there now that people can and should be able to access them?
I think so, and I think that opinion's based on the fact that we actually can't even unload all of the test supply that we do have to people before we have questions of true expiry. So I think if folks are feeling like they don't have access to the tests that they do need to know what's going on, I would direct them to the Better Health Pharmacy to get that free test access. So at this point, I feel like there's widespread testing access across the county, but that is something we continue to monitor to make sure it stays that way.
Got it. Thank you. All right, let me confirm with the clerk one more time. No speakers on this item?
No speakers for this item.
Then a motion to simply receive the report at this point with thanks to Dr. Rudman. Motion by Lee, second by Semidian. Let's call the roll.
All right. Vice Chairperson Lee?
Aye.
And Chairperson Simidian?
Aye.
Thank you. Motion passes.
Thank you very much. Motion carries unanimously. That takes us to item number 13, which is our multi-part item every week, or every month, rather. We have 13A, which is to receive the report from the Chief Executive Officer, Mr. Lorenz. What would you like to share with us, if anything?
Thank you, Chair Semidian. At this time, I don't have anything to add other than what's in the report, but I'm happy to take any questions.
Thank you. Supervisor Lee, I have a couple of questions that are a little random, but I thought intriguing. Mr. Lorenz, and I think my office has given you a heads up on this, there were press reports of some pharmacies in the country releasing prescription data to law enforcement without a warrant. Is this ringing any bells with you? And if so, what's our practice here and what governs our practice here at the county?
I had heard of the article in the press releases around that topic, but I can assure you that in Santa Clara County, our pharmacies do not release any information. If there is a request, that is escalated to administration to work with counsel on the appropriate response.
Have we ever gotten such requests, to anybody's knowledge?
No, we have not received any specific requests directed to our pharmacies.
Mr. Press, Mr. Williams, I don't want to invent a problem that doesn't exist in our county. By the same token, it's never a problem until it's a problem. So I'm just sitting here wondering if one day one of the law enforcement agencies in our county approached us or approached the pharmacy, what would guide their response?
Happy to, yeah. So a few things, just to be clear. So we can and are often under an obligation to produce protected health information pursuant to a court order or a subpoena. The issue with the subpoena is we have to have assurances that the person who is the subject of the subpoena, their personal information, we have to have assurances that they were given adequate notice that information about them is being sought. So we work very closely with the pharmacy department and hospital administration to make sure that any such request like that would be reviewed by the county counsel's office to ensure compliance before we would turn over information. And just, maybe I think I know where you're going with this, maybe I don't, but I just want to also highlight that there is a specific law, a recent law that came out, Civil Code Section 56.108, that actually prohibits disclosure of medical information relating to individuals seeking or obtaining an abortion. So that information we actually can't produce pursuant to a subpoena. So there's much, and then there's a few other sort of categories of information out there that, depending on the type of information sought, there are very specific laws that make the production of such material pursuant to a subpoena even more difficult. So that's California law. We also work in conjunction with the federal HIPAA privacy law, although California is generally much more protective.
So, Mr. Lorenz, what would happen if somebody walked into the Better Health Pharmacy, which has been referenced a couple of times from law enforcement, and said, we're concerned that there's been some misuse or abuse of prescriptions from the Better Health Pharmacy, and we'd like data on somebody's pharmacy use here at Better Health, but we don't have, and forgive me, it's been a while since I've done my criminal procedure class, are we looking for a warrant here, or a subpoena, or a court order, or what's the proper term of art, Mr. President?
All of the above. It could be a warrant, it could be a court order, it could be a judicially authorized subpoena, it could be an administratively authorized subpoena.
That would be immediately escalated to administration within the hospital, and we would, as mentioned, work with county counsel on the appropriate release of the information. It's not unusual for subpoenas to be presented within the health system. They are all directed to administration.
And again, I'm really more concerned about just somebody handing the information over in the absence of any order. Mr. Williams, I'm going to look to you and say, I don't need to do another referral if there's not an issue here. Is there not an issue here because you think this one is handled in our county?
I don't think there is. The policy on how to respond if we get a request is pretty well defined and laid out. I'm not aware of any complaints that we have gotten in the last 7, 8 years. I'm not, when I was county council and now as county executive, regarding any improper, disclosure or improper processing of a subpoena, related to law enforcement walking in. And we have pretty robust processes to handle complaints if they arise, either through the compliance office at the hospital. We have the whistleblower program through county council. So I think we have good procedures in place. That's not to say that there, couldn't be some employee somewhere who does something that's not consistent with policy, but I'm not aware that this is an issue at our health system.
I will just ask as one member of the board that, if there's an opportunity to highlight the fact that there are some due process considerations and that the information should not be shared even if someone is coming from law enforcement absent the appropriate authorization. I think that's helpful, and we can't expect everybody who works at the pharmacy to be expert in this field. So I want to make sure that
I think there's a great opportunity for the pharmacy team to send out a reminder consistent with the new law that Doug noted that took effect on January 1. That is, I think, an opportune moment to be able to refresh staff on those existing policies.
Yeah, Supervisor, if I may, I would just add that it looks like the federal law, at least the HIPAA privacy and rules, are going to, at least it's under consideration to have them move closer to California law to make them a little bit more protective in this area as well, and that's pending right now.
you referenced abortion access in particular in the civil code section. Would that include prescription for mifepristone?
I believe so.
Okay. All right. Well, thank you. I'll just ask for sort of continued awareness. The second ripped from the headlines question I have today deals with the information I saw indicating that Florida had recently received what I think was the first ever FDA approval to import drugs from Canada in an effort to address cost issues. And it occurred to me, well, if a state can get permission, can a county get permission? And is this a line of inquiry we should be pursuing?
Yeah, just to take the legal question first, can we? The answer is right out of the gate, no. Only a state or an Indian tribe can be what's called a sponsor of this type of application to the FDA. So we would have to partner with the state of California, and the state of California would be responsible essentially for this particular program's implementation here in the county. It's a highly restrictive program. On the FDA side in terms of documentation, reporting, testing to make sure, labeling, all these sorts of things. It's only for limited classes of drugs. I don't believe mifepristone would be one of those, actually. And on the other side of the equation, not really a legal issue, but sort of a market participant issue, you have to also have a willing provider. And from what I've read, the Canadian government is not particularly happy with this because, there's a number of states, I forget how many, but there's a handful of states that have also been inquiring about this type of FDA approval to import from Canada. Canada, I believe, only has roughly the same population as the state of California. So just doing the math, Canada is not going to solve our pharmaceutical problems. Now, even assuming if we partnered with the state and Canada was willing and we got these drugs, then we're left with the issue of what can we really use them for. Right now, Florida is only contemplating, assuming everything works out for them, contemplating use of these drugs for state programs, prisons, state facilities, things of that sort. It's, and I defer to Paul and other folks, but I'm not clear that we would get a better deal from Canada than from our 340B program.
Mr. Lorenz?
Obviously, Supervisor, we'd have to see what the cost would be via that route with Canada. But what we do know is California is taking a very different approach. They're looking at actually manufacturing generic drugs to actually lower the cost, and that would be more available to our patient population. We would evaluate cost across the board and determine what the best mechanism is. 340B is very favorable to the county. The question is that the pharmaceuticals that we purchase wholesale for other patients, we would have to evaluate. So that's something that we are following very closely as this issue unfolds.
All right. Well, I have done what I set out to do, which is sort of raise the issue, make sure it was in people's line of sight as we go forward. Obviously, we've had some interest in work and success on the cost of drug containment between Better Health Pharmacy and the Medicist program, and I think it's an area where the state and federal governments have been trying for a long time to get to a better place, and progress has been incremental, but not what I'm sure most of us hoped for. So I'll just ask that we kind of keep it in mind if the dynamics change a little bit and make it worth further consideration. All right. Thank you, Mr. Lawrence. I have nothing else for you under 13A. 13B is the report from our public health officer. We've heard on COVID, flu, and RSV. Anything else, Dr. Redmond?
Nothing else. Thank you.
Supervisor Lee, anything there?
Thank you.
All right. How about item 13C, the report from behavioral health?
Good afternoon, supervisors. Nothing else to add beside what's in the report.
All right. And Valley Health Plan? Excuse me. And Supervisor Lee, you'll lean in if there's a comment or question.
Thank you, Chair Smitty, and you have our report. I would just like to add, we have about 2 weeks left of open enrollment for Cover California, so just want to put that out there. We have seen an increase in enrollment and looking forward to a strong finish.
Thank you.
Thank you.
Custody Health, 13E.
Good afternoon. Nothing to add. Actually, one thing, Supervisor Lee, you asked the last time for a report on the vaccination rates in the jail setting, and we're working on that, so hopefully we'll have that next month. But I do want to say that our efforts to vaccinate continue. There are currently 33 active COVID cases in the jails, all in the adults population, none in their juvenile setting, and we hope to have additional information for you next month.
Great. And since being a group living setting, the chance of transmission is much higher, I think. So I just want to make sure that we continue to message to those that the masks available and how it's important for them to get the vaccination and keep themselves safe. Yeah, thank you.
And I think that's Ms. Carta who made her way down. Ms. Carta, is that you and behind that mask?
It is, and not for this item.
Okay, I'll let you chime in when the time comes. That takes us to item 13F, EMS, Emergency Medical Services Agency.
Good afternoon. I have nothing else to add. If you have any questions.
When are we going to wrestle the data to the ground?
A very good question. We've managed to get it down about 300, and that's it. The data from the previous system is harder to access now that we've gone live with the new CAD system. So they're having a harder time with that. So we're staying on them. AMR knows that they have to get through all of those data elements and report it because we're doing it on a monthly basis.
Well, thank you. I'll just exhort you all to keep at it. We know we have a problem, and we can't really fully appreciate the nature and extent of the problem without good numbers. So I know it seems a little obscure, maybe even tangential, but I do think it's key to resolving the challenge of timeliness. Supervisor Lee, anything on that item?
Not right now, thank you.
All right, and then that takes us finally to the report relating to federal health policy and the budget landscape. Ms. Carter, there's not much left on the agenda, so I'm guessing this might be where you lean in.
Good afternoon, supervisors and county executive. David Campos is meeting with members of the state legislature this afternoon, so ask that I introduce Angie Melton, who is representing the Margolin Group. I'll ask the clerk if she can pull up Angie, who has called in. Angie will be providing you an update with regard to federal legislative matters.
Thank you.
All right. I believe we have Angie Melton, correct? She is currently in our Zoom, and we welcome her to turn on her video.
There we go. Ms. Melton, thank you.
You're welcome. Nice to see you all today. I am here representing Burt Margolin when he can't be here today, and I'm happy to be here. I think I might have presented to you once before in a fully virtual time, so nice to be able to join you virtually when you're there in person. So I am just going to do a quick overview. My first kind of comment will set the stage for the rest, which is that we are currently in the 118th Congress. It's the 2-year Congress, so it's the second session of the 118th Congress. And the first session last year was the least productive session of Congress ever. They only passed about 24 bills through both houses of Congress that were signed by the president. Most of those were non-controversial, like renaming a federal building, things like that. Other recent years, when there was divided government, as we have now, there were, in the first year of a 2-year Congress, they would usually pass between 70 and 75 bills. So it is really kind of breathtakingly unproductive. So obviously, the second year of a Congress tends to be less productive because it's an election year and they have less time in DC and they're more focused on making political points. So that is for me to move on to my next very important piece of this, which is that I know that Burt has spoken with you a number of times about how slim the Republican majority is in the House. Currently, with a couple of recent resignations, it's a 3-vote margin. And then next week, Representative Bill Johnson from Ohio is resigning to take a university job. So that will make it a 2-vote margin for the Republicans. And to put that in perspective, this week there are 2 of the House Republicans who are out for health reasons. So basically, very, very little margin at all on most bills, which means that most things have to be passed in a bipartisan fashion. It's very, very hard for them to pass things that are really partisan. And this slim majority, combined with the deal made by Kevin McCarthy to put some members of the Freedom Caucus on the Rules Committee, means that they aren't even able to get bipartisan bills through regular order. They're having to resort to what's called suspension of the rules, where they skip over the Rules Committee and then they bring bills up with no amendments allowed and a 2/3 vote necessary to pass. So they're in a really kind of precarious place in terms of getting legislation through. I wanted to give that intro because then I want to talk about the few things that have been worked on lately. Just before the holiday break, the House passed a piece of legislation that's going to be important to the county called the Lower Costs, More Transparency Act. That bill would cancel the cuts to disproportionate share hospital payments for a 2-year period. And then it also would extend community health center grant funding. I think maybe Amy can let me know. I think it's around a $30 million change for the county if those cuts are canceled. So that makes a big difference. The bill also has some transparency provisions and related to pharmacy benefit managers, diagnostic and image testing locations, and has some other provisions. The Senate is not going to take this bill up as it was passed. They're working on a variety of the pieces and different legislation, but it is a good sign that it passed the House, given the situation in the House these days. So we're hopeful that that means that will end up being adopted in a piece of legislation that is signed by the president. So currently, I think everyone's heard about the situation with government funding. The delay to the cuts to the disproportionate share hospital payments are linked right now to government funding. So federal fiscal year began on October 1st of last year, but the fiscal year 2024 budget has not been finalized. The delay in passing this appropriation started with former Speaker McCarthy put a continuing resolution on the floor just before the beginning of the fiscal year. And that was an extension at last year's level, just a straight extension. And after that was, as you've heard from Bert and you've all seen in the news, was when he was ousted as Speaker. So since then, there have been a lot of issues trying to figure out what's going to happen with government funding. The Freedom Caucus was pushing Speaker Johnson to use lower funding levels than were adopted during the Fiscal Responsibility Act. But he actually did come to an agreement a little over a week ago with Majority Leader Schumer in the Senate that they would be setting the top line appropriations numbers at the level agreed to in the Fiscal Responsibility Act. Made some of his conference angry, but it does appear that that's going to hold. And they've now introduced another continuing resolution that, should it pass this week, it will prevent a government shutdown and keep the government running. 4 of the pieces of legislation, 4 of the appropriations bills that are linked to the agencies will be extended through the 1st of March. And the other 8 pieces of legislation linked to agencies, along with the health extenders, which is the disproportionate share hospital cut delay, those will be extended through March 8th. And there is great hope that once this continuing resolution is adopted this week, that the House and Senate Appropriations Committees will be able to work together on the budget numbers, and that the House and Senate committees that are in charge of these health extenders will be able to come to agreement so that they can pass legislation to finish all of that before the expiration at the beginning of March. The other piece is that Congress is continuing to work on a supplemental funding bill for Ukraine, Israel, Taiwan, and also to potentially include border provisions. There was a meeting at the White House today that included leaders from both parties and both houses to talk about the supplemental deal. It's not clear how much progress they actually made, but I do know that that minority leader in the Senate, McConnell, has said he really wants there to be this supplemental appropriations bill on the floor next week because these areas of the world really need our assistance. So that is my kind of summary of where things are right now. I wish that I had more to report, that there was more happening, but there's not a lot happening, and I don't anticipate that a ton is going to happen between now and the election. Happy to take any questions.
Thank you. Let me just ask, you referenced the 2-year, I'll call it abeyance on dish cuts.
Yes.
This is an issue that we've talked with Mr. Margolin about in the past. It seems, in my experience, that this issue is never resolved. It's always just kind of punted for a little while again. Why is that? I remember there's a reason. If I remember, I just can't remember what the reason was. That rather than just saying we're not doing that, we kind of keep everybody on the edge of their chair with these cuts putting the cuts in abeyance for some defined period of time.
So the cuts to disproportionate share hospital payments were used as one of the major pay-fors for the Affordable Care Act. And so those cuts were put into place, and that was, paying later for the money that was being authorized for the various expenses of the Affordable Care Act, including, but not limited to, the Medicaid expansion in the states that took up the expansion. The idea at the time was that all states would expand Medicaid, and it would mean that those hospitals that had been getting the DSH payments wouldn't need them as much. So they would be able to cut them. Obviously, that has not come to pass because, number one, not all states took the Medicaid expansion. And even in a state like California, those cuts would make a massive impact on the public health system. So instead of just saying they're not going to cut the DSH payments, they keep delaying them because for budgetary reasons, they're able to say, we're going to do these cuts in a few years. So that means we're still paying for the money that we've already spent on the ACA.
Ms. Melton, I don't want to put words in your mouth, but it sounds to me like essentially we are maintaining a fiction for purposes of...
Yes.
Yes, yeah, I'll just, I'll let it go at that. Thank you. All right. All right.
Absolutely, we are maintaining a fiction. It's a budgetary game, and it has to do with this requirement that all expenditures be offset in some way.
Got it. Supervisor Lee, any questions or comments on this piece of the item 13?
Not at this point. I think it's just disheartening. It's third time I used that word today, to hear how unproductive our United States Congress has been. And that hopefully this meeting with the president today, summoning the leaders, would result in some significant development that we need, especially with the Ukraine, which obviously is fighting a real war, and at the same time without the necessary logistics. Being a former supply officer of the United States Navy, I certainly understand the need and how urgent that is. I just said thank you so much for the report. We have a tough Congress to deal with, and with a two vote majority now of the Republicans, I'm hoping that maybe it will come to consensus that those far right extreme Republican congressmen will be less and less influential in the future. Thank you.
Ms. Melton, I just want to go back to the numbers which you had at your disposal a minute or two ago. Did I understand you correctly to say that in the first year, meaning 2023 of this session, a dozen bills made their way through both houses of Congress? Was that?
2 dozen. 2 dozen.
2 dozen. Thank you. I think I missed that. All right. And that's compared or contrasted with typically 75 in the first year of a 2-year session?
75 when it's been divided government. Actually, in the first year of a 2-year session where it's not divided government, there's over 100 bills that pass. But, looking back on the Obama years when there was a divided government, it was about 75. And back to when Bill Clinton was president, again, in the 70 to 75 range.
Got it. Thank you very much. I will say thank you. I have no other questions. I'll say thank you to Ms. Carta as well. I'll look to the clerk to see whether we have speakers on item 13. Any or all parts?
We do have one request to speak virtually.
Great. Let's go ahead and hear from that speaker. And under the rules of the board and in this committee, we allocate up to 2 minutes for comment on agendized items.
All right, thank you. Our speaker is Paul Soto. Paul, we are unmuting you. You will have 2 minutes to speak. The timer will begin when you begin speaking.
Thank you, Paul Soto from the Horseshoe. I want to thank Sherry Terrell for the letter that she wrote on behalf of behavioral health, December 4th or December 5th, when the subject of the implementation of AB 43 had come up, or SB 43. The letter was very consistent with what it is that reflected the sentiments of the community. That this is something that number one, the infrastructure to accommodate the implementation of such a bill literally just does not exist. So from a practical standpoint, it's not something that can be done. Secondly, though, from a more implementation standpoint, I'm concerned about what the mayor is doing. Now, what the mayor is doing is that he thinks that he's going to get this downtown association and hire a bunch of clinical social workers, because a clinical social worker is really the only one that can be certified to have on her say or his say, to point to somebody and have a cop arrest them and put them in jail because that clinical social worker has determined that the person doesn't have the capability. They can't feed themselves, they can't house themselves, they can't take care of themselves, and they're suffering from alcoholism and drug addiction. Ergo, you got to go now. Put your hands behind your back. And this is what the mayor's doing. He's pushing this, and he's pushing it hard. And so I need to remind this committee that what just happened, I don't know if you discussed it earlier, but what happened over the weekend with the Supreme Court passing that, allowing the Supreme Court to hear the case. But for right now, it is still legal to be on the street and not have somebody go and pick them up.
Thank you, and that concludes our speakers.
Thank you. Then Supervisor Lee, I believe I can turn to you and ask for a motion to approve item 13 in its entirety.
So moved.
Motion by Lee, second by Semidian. No other speakers, Madam Clerk?
That is correct.
Call the roll, please.
Vice Chairperson Lee?
Aye.
And Chairperson Semidian?
Aye.
Thank you. Motion passes.
Thank you very much. All right, ladies and gentlemen, thank you very much. That takes us through the end of today's agenda, and appreciate your help in moving these items along thoroughly but expeditiously. Without objection and hearing none, we are adjourned for the day. Thank you all. Take care.